of ROP and tele-screening, how to proceed further in further promoting ROP and dealing complicated cases. Sir, to you.
Thanks, Anu, and thanks, Rekha Madam, for having me here. So I'm just filling in for Dr. Parag, who is not able to come because of some mother's health issues. So when you are dealing with, as rightly pointed out by both Dr. Alex as well as Dr. Lekha, that when you are dealing with a premature baby, we want the pediatrician to manage the baby in such a way that we don't get any sort of retinopathy or at the maximum milder stage 1, very mild disease. But in case they go on to treatable disease, like Dr. Lekha pointed out the guidelines of the early treatment ROP studies. So we can see that timely management with both injections and laser should be able to prevent and give a very nice outcome. You can try to limit the amount of laser and a very favorable anatomical outcome also. But there are occasions where, in spite of all these, we end up with very bad disease because of the tractional complications or because of improper sensitization of both the NICU personnel and doctors. They end up not getting screened and then end up with such a eye. So we don't want to see this, but in case that happens, we need not lose hope and try to intervene as early as possible. And as I already pointed out by the first speaker, you can see that we have the stage 4 and stage 5. 4 meaning that if it's in macula involved or not, depending on that, we have 4A and 4B. And in stage 5, it is total retinal detachment. So before we consider surgery in these patients, we should first thing is to see whether the patient is fit enough to get operated. We have had patients who are lowest birth weight is around 650, which are operated not at the time of surgery. So we had to call the NICU in charge along with the anesthetist to be present in the theater during the surgery, because they are very critical and they may collapse at any time. So we need to have very good backup. So other normal babies, we operate and immediately shift to the NICU after the surgery. So the baby should be fit enough to undergo this surgical procedure, anesthesia procedure, and proper evaluation to get the anatomy of the disease by both indirect ophthalmoscopy and ultrasound is very critical to understand how to deal with these eyes. So a very early mild regressing disease, when there's a mild TRD, you can always observe. But for stage 4A, a little bit more on the periphery, you can do scleral buckling, which causes alteration in the fibrovascular remodeling of the fibrosis, which can lead to reattachment of the retina. But that can be seen only in a very few percentage of eyes. So usually in significant disease, we need to do some sort of intraretinal procedure that can be a vitrectomy with the conservation of lens in patients who have a stage 4 disease. And in stage 5, there's no option, but you have to deal with we have to remove the lens because there's no space between the lens and the retina. And sometimes when there's corneal complication and corneal scarring, when patients come in very late, you may have to do a combined keratoplasty and open sky vitrectomy in those patients. We had 2-3 cases which are done, but they did not do well. So that's something which you don't really want to do actually. This is one of the older videos showing the 20 gauge surgery being performed in stage 4 disease. You can see the bulky the instruments, and you have to keep in mind that the preterm babies have a very small eyeball, and using these bulky instruments was a little bit difficult, and the suturing in the thin and elastic sclerosis was not very easy. So recently we have all shifted to both 23, 25 and 27. So we usually prefer 25, and sometimes we do 27 also, depending on the instruments available in our hospital. So which makes life a little bit much more simpler, and you can get away without suturing in a significant number of people if it does not, the ports do not leak. And in stage 4B, the disease surgery is very minimalistic. We just try to remove the traction. There is no need to induce PVD. There is no need to peel off all the membranes. So we try to limit and release the traction. And in case the laser is inadequate, to do some little bit of laser and stop there. So actually, the surgical time is quite less compared to adult vitrectomy in either an RD or a diabetic retinopathy. Only thing is you should take care to avoid lens touch and don't be too aggressive trying to peel all the membranes and ending up with the breaks. Because once a break happens, that is the end of the story. There are a few cases where in spite of breaks they have survived, but otherwise a break means the surgery is over at that point of time. In stage 5, as you can see here, we have to sacrifice the lens, and usually we try to go anterior to the iris, because we don't know what are the fibrotic elements present behind the iris, which may cause, we are trying to introduce instrument that can produce a retinal dialysis at the base. So to avoid that, we try to go in anterior to the iris plane, and also try to remove all the lens elements, because remnant capsules can produce considerable postoperative fibrosis, thereby causing late failures. So first thing is to remove the lens and all the capsular elements, taking care to remove all the capsular elements, and then trying to do this two-hand technique to avoid traction on the periphery, because if you induce a little bit of traction on the periphery, it can lead to retinal dialysis in the periphery because of the significant fibrotic elements. And first is to divide the central fibrotic element into multiple quadrants, like dividing a pizza or a pie, whatever you call it, and then you try to open up the funnel. And once you are sure that you have released most of the anterior traction, then you can sometimes inject a visco. Sometimes you may have to do a subretinal drainage like you do in scleral buckling to sort of mobilize some space for doing all these procedures, but that's in a few percentage. But most of the times we can get away without drainage. But in advanced cases, or when there's altered blood in the subretinal space, you may have to do external drainage to make up for some space. You may close with the BSS or with the visco to prevent reclosure of these folds of the retina. So if you are injecting a visco, keep in mind that the glaucoma postoperative should be taken care, which is sometimes not very easy. So you have to be aware of that also. So in case we can get away without injecting visco, that is okay. But in case you need it, don't hesitate to use it. This is one of our older analysis. In 2009, we did a small analysis of what the results were in our population of babies. So we had around 33 cases, of which we had a success of around 48%. This includes both stage 4 and stage 5, as you can see here. And as you can see here, the endemic success in a stage 5 baby is not that very great. So which is something which we don't want to encounter and operate in these cases. Some photographs from that study. So you're dealing with this surgery, you have to understand all these implications of the adhesions from posterior to ridge, ridge to ridge, and anterior to lens to ridge, and as well as periphery to ridge. So unless you understand these things, you can easily cause retinal tears and end up with a failure. And the distance which you enter the eye, as already pointed by Dr. Lekha, so it depends on the age at which you operate, and this is the millimeters from the lens, the limbus which you enter to avoid both lens touch. And because the pars plana from the baby is not that very well developed, you have to go through the pars placata, and usually it's around 1 to 2. And initially we did not have the short trocar cannulas, because when you're introducing adult cannulas, you can easily injure the opposite retina or sometimes the lens also. So now we have the short, both from Alcon as well as Aurora, we have the short cannulas. But initially what we used to do is, so you introduce a small silicone tire, 240 tire, to create some space between the tip, so that the entry of the trocar inside the ear is lesser, thereby avoiding unnecessary injury to the opposite side retina or the lens. So this we just hook onto the trocar cannulas and then use it as it is. So now we do have short cannulas, so now we have stopped doing this, but this was the initial sort of modification which are using to prevent injury. So this helps the entry of the trocars to shorten the entry of the trocars. There's again some results from that second study which we did. So this is actually one more study, a recent study for stage 5 25 gauge surgery, and you can see here in this now we had better results compared to the older study, which included both the stage 5 also. And as already pointed by the first speaker, the stage 5 you have A, B and C depending upon whether disc is seen and disc is not seen, and whether there are anti-segment complications. So there is a small study, nice study to prognosticate the outcomes of stage 5 surgery. And this is one of the studies by Dr. Mano et al. So around 54 eyes were included, and they showed that the complete reattachment was obtained in stage 5 eyes where the disc was visible, and 39%, 40% in patients who had RD with the invisible disc, and in stage 5C they were considered to be inoperable in most cases, because I told you these corneal complications may warrant keratoplasty, open sky vitrectomy. We have done only 2 cases in hospital till now, both were failures, so we have stopped doing that actually. We have to do keratoplasty along with the surgery. So one take-home message is that do not give up in these babies who end up with the serious complications, and long-term follow-up, as again Dr. Lekha pointed out, these people can end up with late, even after the 13-14 years, they can end up with the breaks and RD. We have 2 cases of early vitrectomy we did, and after 13 or 14 years of age group, they have developed peripheral tears ending up with the recurrent retinal detachment. That was initially TRD, which now went in for a REGRD after so many years. So apart from that, you have to watch out for the refractive errors, the glaucoma part, which is very significant, which may be missed by routine people, and also the amblyopia management in these kids. And sometimes these kids may be not normal, so they may have cognitive disability, which also needs appropriate addressed. It has to be addressed. And in cases where they end up with very poor vision, don't just send them home. Always keep tie up with some facility which gives them both educational and vocational guidance, because a lot of parents are not totally lost, and you have to guide them to so that the kids do not end up as a vegetable at home. So try to help them to move on life in spite of having a poor vision. Thank you for your attention.
Thank you, sir. So you can continue with the same next talk also.
Okay. So this is regarding the ROP telescreening which you are doing in a hospital, a pet project of Dr. Parag. He's put a lot of passion and effort into this because initially we felt that we are only able to, the limited manpower which we have at Arvind, we are not able to cover a lot of NICUs, both surrounding both the multiple, we have around 4 or 5 districts around Coimbatore, which we are not able to cover. So, as already pointed out the first speaker, we have a considerable problem at hand. So, as I told you, that there is limited resources for, both in hospital or anywhere else. So, with the aid from the US aid, we started this ROP SOS, or Retinopathy of Premature Eradication, Save Our Sight project with the help of US aid, United States Agency for International Development. And later on, we have some, for the second phase, we also got some support from Mr. Subrato Bagchi, who was the founder of Mindtree. So this is what our aim was, to set up a unit which can move around with the shuttle, RedCam shuttle, which is used to capture fundus images in neonates and kids, and use that as a screening tool so that we can avoid sending doctors and we can send trained personnel. So this is what this is a RedCam shuttle, which is a sort of a mobile version of the RedCam, which is a little bit less heavy and it can be easily moved around. This has got a laptop instead of a desktop. But otherwise the kit is almost same only, a little bit lesser weightage compared to the original thing. And these so-called trainers, screeners are trained by using the model eye in the initial phase, and then in the hospital under guidance, we have either a senior trained person or the doctor himself. They are trained to screen on premature babies. So after the training, they are satisfactory and their competence is satisfactory. They are sent in a van to all the peripheral NICUs, and each week we have one hospital. We have around 2 vans which move around the various districts, and this van is customized to carry this RedCam shuttle. So it has got a spring spring bonds, which helps to prevent and a padded compartment for preventing the damage of the RedCam shuttle when the van bounces through uneven roads, so it prevents damage to the shuttle. It's got a padded room and a sort of elastic buckles to move it around and also not get injured. This fan facility also has the mobile unit, the Iridex laser, which can be taken in case a patient is screened to be found to be having a treatable disease. Then the doctor visits the hospital in the next strip, and they can do the laser at the NICUs in case the patient is not fit enough to be moved to the main center. So this image which was shot over, captured using the RedCam or then transferred to the base center using the cell phone GPRS and the current 4G and 5G technology. And we have doing this retinopathy screening called the Arvind diabetic retinopathy eyes screening, which we have the software for screening a diabetic retinopathy. So a modified version of this software was initially used. We have been using it for the retinopathy of premature screening also. So the same software which we use for DR screening. Again, we have a mobile slit lamp as well as fundus camera for DR screening. So same what we used in that, it's called the address system. So that was used, modified and used for the ROP screening also. This is currently what are some of these districts which you cover from Coimbatore. So we have few districts in Kerala also, but mainly we are dealing with the Karur, Namakkal, Erode, Tirupur and Salem districts. So this is what we do. Apart from the screening process itself, we have a lot of posters in the entrance of the NICU so that the parents are also aware of what should be done for their premature babies. Apart from the general care, that eye also needs to be screened. We also the NICU staff to distribute these pamphlets so that in case they get discharged, they can come to the hospital for the follow-up of the screening. And also people who have been enrolled in this ROP SOS, we send regular SOS SMS in case they skip their follow-up visits. So totally, in this project, in the first phase, we from 2015 to 2017, around 7,000 babies were screened, of which 111 babies had found to be severe ROPs, and laser was done to 129, and 84 patients got injection, and 4 eyes ended up with a significant disease which needed surgical intervention. Just showing a video of how this is being done. As you can see here, this is the RedCam shuttle, which is being loaded onto the so-called padded compartment with the spring bonds or what you have here, and then this is along with the van, driver, one more external staff for the helping the driver, and also two trained people go there. Around 4 people travel in the van, and once they capture image, this is sent either to the base unit where you have a desktop, but in case the surgeon is not available in the hospital, this can be accessed from a cell phone also. The software is installed in some of the we have 3 doctors who have their software installed in their cell phone also, in case they are out for some reason, for lunch or even for other reasons. So our turnover time is within the first 45 minutes, the result has to be delivered to the hospital. So we have that as a sort of an endpoint, and so in case the patient is not available, the doctor is not available in the base hospital, he can always use the cell phone to use the same software and identify and give the advice so that whether they need to be treated or observed or come back to the base hospital for the follow-up. So all this advice is given within 30-45 minutes at the maximum for 1 hour. So there was also some publication of where we saw other diseases apart from ROP, which includes routine birth hemorrhages, colobomas, optic disc anomalies, lipoma retinalis, CHERP. So all these multiple other disorders were identified during the ROP screening, which was we published that results also. Sometimes this may help to pick up other diseases apart from this thing. So apart from this, we tried to sort of educate the paramedical personnel, and we have conducted so many CME programs which showed a good impact on the follow-up of the number of patients who were able to enroll into the ROP SOS program. So again, I was discussing with Dr. Lekha also. In one of the NICUs, we had 2 major NICUs in Coimbatore, and one of the NICUs, we had a very significant operable ROP coming from one of the NICUs. So what we did was, we tried to assess what is happening wrong in this, and we realized that there was a lot of variation in the oxygen saturation of the babies because of this funnel-shaped instrument which they were using it, and whenever the baby moves, it will just come off, and there was a very less care because of the extensive crowd which is one hospital, NICU had a little bit of less crowd, so they're taking much more care, whereas other hospital was almost like a government hospital, so much load going and coming out, they were not able to retain babies. Even a little bit of stability, they'll send home, then the patient will come back again with the respiratory distress. So the oxygen saturation was moving up and down in these babies, and that was the reason why they developed a significant ROP. And when we tried to educate the pediatrician, and the pediatrician understood what was happening, and so they were able to shift all their practices, and now we see very less treatable ROPs coming from that center also. So that is one of the major impacts which happened during this screening protocol. We were able to identify some of the issues with in the NICU management of preterm babies. So we also have been able to expand our screening area till Krishnagiri now. So that's what we have been doing. And now we have had a second van apart from the first Jeep. So first van, now we have a smaller version Jeep from the Mindtree support. And so we've been doing this, and now recently we've been started to use AI. So our DR screening program now, because initially we had doctors sitting and reading the images and giving advice, but now we had with the tie-up with the Google we had for the DR, we had a tie-up with Google, and now almost 99% of the images are being read by the AI, and no doctor does the reading. And similarly, we have been doing this AI reading, and now it's currently we started now. Till now, the validation was going on with the iTelligent, this Dr. Paul, Dr. Peter Campbell, and Dr. Michael Chang. So IROP, there was a project, and they did this both in the West as well as in India. So they have had considerable specificity and sensitivity in this AI, and now we are trying to implement in our hospital also. So now the load on the doctor, because they have to take care of the routine OPD work, surgical work, as well as the screening works. Now we are a little bit more happy that our workload is less. So this AI, now we are just setting in. So hopefully this will decrease our workload in the coming years to come. So we are also had a small comparison with the RedCam as well as the low-cost handheld cell phone-based systems. Unfortunately, these handheld simpler devices were not able to give that very nice photographs like the RedCam could, and there was a very intense, like what you call a skill intense procedure. So even if the screener is not that very skillful, they could not get clear images, especially of the periphery. So right now, the truth is that the cell phone based cameras are not a very reliable tool for, especially for ROP screening. So it's better to use the established capture systems like the RedCam or the 4S. As I told you, the cell phone, this is the limitation. So as I told you now, with all this, we have been able to take care of a larger population which was not able to do when you are doing a physical doctor screening. So with the help of the paramedical staff, we have trained them, and now the area and the number of children we are able to cover is very vast, and this has helped to reach out to much more peripheral NICUs. And this has made a really big impact in our care delivery to the preterm babies. I'll stop here. Thank you for the attention.
Thank you, sir. Thanks for this really enlightening talk on telescreening. We actually need this. And this can change the whole ROP game all over India. And the AI is giving significantly good results. It's a good thing.
And we should not have a hesitation to accept the advances in technology. I think first thing is we should overcome our mental block, and we have somebody to share his experience so well. So that was very useful. Thank you so much. And a special thanks for accepting it in the last minute and covering it for Dr. Parag. Thank you.